Yeah, hi everyone. So today I just want to have a quick recap of periapical pathology. I have already posted the video related to the pulpal diseases. Now we are going to have a look over the sequel of the pulpal diseases, that is periapical diseases. So before going in detail, I just want to have a comparison of acute and chronic inflammation. As we know that it is of shorter duration, it is of longer duration, and the inflammatory cells that are present in the acute inflammation are neutrophils, whereas in the case of chronic inflammation are lymphocytes and plasma cells in particular. And if you go into the vascular changes, it will be acute vasodilatation, which increases the permeability, whereas in the case of chronic inflammation, it is granulation tissue formation by a mechanism called as neurovascularization. So edema will be very peculiar in the case of acute inflammation, whereas chronic inflammation, it may or may not be present. So fibrosis, as you know, it is a chronic stage. It is seen in the case of chronic inflammation, which is absent in the case of an acute inflammation. So systemic manifestations that are seen in the case of acute inflammation are fever and leukocytosis, whereas in the case of a chronic inflammation are low-grade fever, weight loss, and anemia. So coming to the cardinal signs, I just want to have a look at these cardinal signs. So first four are the cardinal signs that are given by Celsius. So the fifth cardinal sign was added by Virchow. So these two questions are very important. Okay, the first four cardinal signs are given by Celsius, whereas the last one, that is the loss of function, was given by Virchow. So if we go in detail, rubor, that is redness, is due to increasing in the vascular permeability, whereas the tumor, the swelling, is due to the exudation of the fluid, and color, that is heat, is due to the increasing in the blood flow, which releases inflammatory mediators, which raises the temperature, and the pain, the dolor, is due to the stretch of the receptors that by the inflammatory exudate, which causes pain. So loss of function is a combination of all these four factors. It's to the loss of function, which is a combination of all the four above factors. So this is one of the most important table which helps in eliciting the relationship between the pulp and periapical diseases. So the main concern is, I feel like this is the main important concern you have to know about, because many of the questions will be there. They will ask questions related to the flow chart, and if you go even if you go through the dental pulse, there are few questions which are related to this flow chart. So periapical granuloma can be a sequel of periapical abscess, or can be a sequel of apical periodontitis, which leads to periapical cyst. The periapical cyst, which leads to the bony defect, that is osteomeritis, which leads to the periosteitis, which can be converted into a generalized abscess. Okay, it's not a periapical, it's a generalized abscess, or it can be a cellulitis. And the main difference between abscess is it is in a particular space. Okay, it is a accumulation of a fluid in a particular space, whereas it's a generalized accumulation of fluid in subcutaneous space is called as a cellulitis. So these are the three important points. Okay, the sequel of the periapical infections are related to three factors. One is the generalized resistance shown by the host, second one is the local resistance of the host, and third one is the microorganisms, the population and the virulency of the microorganisms. So the balance between it's going to be a balance between the host response and these three factors. Okay, these three factors are going to play a role, and we need the balance. So the things will go on. Like it can be if the balance is proper, the disease will be in the chronic state. If not, it moves to the acute state. That's what it means. So this is one of the important classification. I think you have a question related to the residual. Okay, this is a repeat question that is asked in the KSET. The question is, what is the WHO code for the residual cyst? The answer is K04.81. Okay, they can ask any questions like periapical abscess with sinus tract opening. So this is the code for periapical abscess with sinus tract. And if they mention the landmark where the sinus tract is opening, for example, if it is antrum, that is a maxillary sinus, the answer is 60. If it is in the nasal cavity, the answer is 61. If it is in the oral cavity, the answer is 6-2. If it is on the skin, the answer is 6-3. So this is how you have to make a note of this classification, which is very important. There are few questions related to the classification previously asked. This is the answer. K is 04.81, that is the residual cyst. So I feel like this is not much important, but please make a note. There are two types of periapical cyst. We'll discuss in further slides. That is true periapical cyst and pocket periapical cyst. There is a slight difference between these two. I'm going to discuss about this in the next slide. So coming in detail, I have already explained you the diagnosis part of these pulp and periapical diseases in the last video, but please make a note the term symptomatic apical periodontitis. It's mostly acute form. Okay, means the symptoms are there, means the pain is there for the patient. That is symptomatic apical periodontitis, means pain will be it will be tender on vertical percussions. Like whenever you percuss the tissue, there will be pain. That is the acute sign that is seen in the case of symptomatic apical periodontitis. Whereas asymptomatic, the sign is the diagnostic sign is the radiograph, where the patient may not always give you signs and symptoms of pain, but you can see radiographically, you can appreciate the loss of laminar dura and PDL widening. So in such cases, you can go for this asymptomatic apical periodontitis, where the symptoms are absent but there is an inflammation to the periodontium. So what are the changes that takes place? Like once the disease started and once the body is responding, there will be formation of new vessels, fibroblasts, activation of osteoblast, and they lead to formation of immature collagen fibers, which are going to be replaced to form the bone and the PDL. So if the balance is proper, like the defense of the host and the bacteria, the bacterial irritants, if they're balanced, then the system will be asymptomatic. Infection will be there, but it is asymptomatic. If the bacterial potency is more when compared to the defense factors, then it leads to phoenic abscess, that is acute exaggeration of chronic abscess, where the bacterial potency suddenly increases when you compare with the defense factors. So that condition is called as a phoenic abscess. So this is one of the way to differentiate periapical granuloma. Okay, it can be periapical granuloma or periapical cyst or abscess. In particular, it may be cyst or granuloma, which can be confused with periapical osteofibrosis. It is nothing but cementoma. Okay, the main difference is you have to go for the vitality test. Here periapical granuloma or cyst, it is non-vital, whereas cementoma or periapical osteofibrosis, it is vital. So periapical changes are they look similar, but you can see a deep dental caries involving here, whereas there is no such dental caries involving in the case, and this is vital teeth, whereas this is non-vital teeth. So this is how you can differentiate it. There are many questions related to this periapical granuloma or cyst comparison with apical osteofibrosis or cementoma. So this is one of the important concept where there are lots of questions related to this, particularly in the AIMS examination. Okay, so Cornfield mountain pass theory. This is a concept which helps in explaining about the periapical inflammation or periapical process. Okay, the zone, it divides into a few zones: zone A, zone B, and so zone C. And zone A is compared to the bacteria that is present in the infected root canal, which invades the foramen. You can see a bacteria. These are the bacteria that are present in the canal, and these are the bacteria. This bacteria is called as a zone A, whereas coming to the next is the zone B. Zone B is the exudate. Okay, exudate that is going through the apical foramen into the area. This is called as a zone B area, exudate and the granulation tissue. And zone C is the zone of bacteria. It's completely bacteria. So this is how this can be compared to a mountain pass, where the bacteria are present in this. Once the bacteria enters the field, the defense cells which are present in the zone C are going to attack and destroy the bacteria. This is how the mountain pass theory goes. So next we need to learn about the periapical radicular cyst. The main important thing is it is surrounded by the granulation tissue, and in few cases it is encapsulated by the peripheral fibrous encapsulation. And the most common etiology is trauma, and most commonly seen in the case of maxillary anteriors. Okay, so differential diagnosis, it is not that important, you can just have a look. Normal cavity appears dissociated from the root apexes on different angulations, so different radiographic angulations are necessary to identify it radiologically. And this is the one of the important thing. You can see that's a non-vital teeth, and you can see the periapical lesion. This is the radicular cyst, whereas you can see the same cyst between the lateral and the canine, that is the globomaxillary cyst. These teeth are vital here, whereas here it is non-vital. This is an important thing. It is very important to differentiate it from the traumatic bone cyst, which is also called as an hemorrhagic cyst or extravasation cyst, and it is the hollow cavity that is not lined by epithelium, so it is called as it is one of the type of pseudocyst, and the treatment for this is induce the bleeding. Okay, so induce the bleeding, so that is the treatment plan for this. And rest everything is fine. They are these radicular cysts are originated from epithelial cell rests of Malus that is present in the periodontal ligament, and the choice of treatment is root canal treatment followed by the periodic observations. If the root canal treatment doesn't provide a favorable outcome, then you need to go for the surgical removal, that is enucleation. So there are few theories that explain this periapical cyst. One is a nutrition deficient theory. So here the nutrition deficient theory, the central cavity is as it grows, it moves away from the nutrient sources, that is the blood sources. So the cavity resulting in the center of cells as a liquefaction necrosis occurs. That is called as a nutrition deficiency theory. There will be deficient in the nutrition. And the second one is abscess theory. Abscess theory, an abscess cavity is formed in the periapical connective tissue, and subsequently the abscess is completely surrounded by the epithelium because of the natural inclination of the stratified squamous epithelium to line the exposed connective tissue. So in the second theory, an abscess is formed. So upon reaction, the body secretes epithelium lining, so it grows on with epithelium. So this is called as an abscess theory. This is the second one. The first theory is there will be center cell on which this epithelium is formed. So once on the epithelium is forming, so there will be the distance from the center to that of the outermost nutrient supply will goes on increase, and finally the central part will not receive any nutrition, so it undergoes necrosis. So this is the first theory. And the third theory is a new theory, that is merging of the epithelial stand theory. That is, so epithelial stand continues to grow. So epithelial stand, they continues to grow in all the directions. At last, these directions they combine and merge at one point to form an abscess. So this is the abscess or cyst. This is what the third theory is. And coming to the contents, it is lined by stratified squamous epithelium, so it is called as a normal cyst. The fluid is clear amber or viscous yellow. It contains cholesterol crystals, and I hope you know cholesterol crystals are present in one of the zone of the fish zones. That is the most common question. The answer is zone of irritation. So zone of irritation is going to contain some sort of cholesterol crystals, and that is a peculiar sign that is seen in the case of a radicular cyst. And ruston bodies, foam cells, bacteria and cells present in the various stages of disintegration. So this is what I was discussing previously. Periapical cyst is actually of two types, that is periapical pocket cyst and periapical true cyst. As you know, true cyst is something that is completely surrounded by the epithelium. You can see the true cyst, it is completely surrounded by epithelium, whereas periapical pocket cyst, it is not covered by epithelium completely. It will be like this. It has a communication with that of the canal. It has a communication with the root canal, so it is called as a periapical pocket cyst, whereas periapical true cyst, it's not going to have a communication with the root canal. It is separated or detached from the root canal, and it has complete epithelial lining over it. So this is very, very important slide that is concerned about the differences between the granuloma cyst and abscess. If you go in detail, granuloma is chronic, it is non-painful, it has a definite outline, and it is smaller in size. Clear? So whereas cyst, it is a chronic, same of granuloma, non-painful, it is bigger in size when compared with that of the granuloma, and it has more protein and albumin content. And the important peculiar feature for the in a radiological point of view is a sclerotic opaque border. You can clearly see, whereas you can see the border of granuloma, it is fine here, whereas here you can see the sclerosis of the border. That is cyst, and this is what granuloma is. And abscess can be acute or chronic, painful or non-painful. You can see sinus openings in sometimes, spirillous in sometimes, and definite outline, diffuse outline will be seen. So the ill-defined radiolucency will be seen. It's not well defined when you compare with that of the cyst or granuloma. So the confirmation of this granuloma or cyst or abscess is done by the histological method. It's an MCQ again. So this very important slide which covers the differences between the cyst and granuloma and abscess, and the confirmation is always by the histology. So condensing osteitis, you can see a condensing osteitis. It is a reaction showed by the bone or the body. So most often time you can appreciate this radiologically. The teeth can be vital or non-vital. You can see condensing osteitis in vital tooth also. It can be vital or non-vital, not always non-vital. It can be vital or non-vital. This is one of the important diagram based stuff. That is actually a healing sinus tract is called as a perilous, which can be called as a gum boil, and the gingival abscess. They may look similar, but they are different. Okay. So next is a chronic alveolar abscess. Chronic alveolar abscess is a long-standing, low-grade infection of the radicular alveolar bone, and the source of infection is obviously the root canal or a dental caries. And you can detect the sinus tract by using Ghatapacha. Preferably number 25 Ghatapacha is used for the detection of this sinus opening. And radiograph should be taken after the insertion of the Ghatapacha cone into the sinus tract. Often shows the involved teeth by tracing the sinus tract to its origin. So you can find out the origin where the infection starts. When no sinus tract is present, the cellular debris and the bacteria are phagocytosed by the microorganisms, and the fluids are absorbed through the blood and the lymph channels. So diagnosis, these are not much important. Differential diagnosis too. I mean, I have already discussed about this. As a result, a poor or an accurate diagnosis can be done only when a tissue specimens has been examined microscopically and should be differentiated from the periapical osteofibrosis, that is called as a cementoma or ossifying fibroma, which is associated with the vital teeth and requires no endodontic treatment. That's what I was discussed in the previous slide. And we need to learn few things about the pus that is collected from this periapical abscess. The pus that is collected from the periapical abscess is acidic, that is a known thing, and the value ranges from 6.68 plus or minus 0.2. And this acidic environment is the environment that helps in resulting in the digestion of ingested microorganisms. So a specific environment should maintain. And during the phagocytosis, polymorphonucleosides degranulates and releases enzymes which activate in the acidic pH only. So that is one of the reasons where an acidic pH has to be maintained. So an important note is, that therefore it is believed that inflammation or infection tissue has a low pH, and acidic pH may have adverse effects on providing the adequate local anesthesia. The local anesthesia may not work in the acidic pH. And why the local anesthesia may not work is the next point. That is, acidic pH as a result of the pathological nature may decreases the concentration of unionized fraction of local anesthetic. So once the local anesthetic is given, it's going to dissociate into ionized form as well as unionized form, right? So this unionized form is lipid loving, it is lipophilic, and it is main responsible for causing the anesthetic effect. So whenever there is an acidic pH, this unionized form is decreased, and that is the main reason for the anesthetic form. So the anesthesia or the anesthetic effect is decreased. So people who are preparing for AIMS, they can ask this as a diagram based question. This is actually an APECSM procedure. It's actually an instrument which is made up of don't go much detail, which is instrument that is made up of night. Okay, so these are going to have two instruments. Okay, one which works at a speed of 200 to 250 rpm, and second works at a speed of 5000 to 7000 rpm. I'm just going to have a look at the diagram. You will get a clear cut idea. So it's going to have a bend like where you can insert into the periapical region and start rotating it. So it's going to clear all the granulation tissue that is present at the apex, and once you're done with this, you need to irrigate with the saline and the flesh will come out. So this is what the apexum is. Just a diagram based question, which is definitely important for the people who are preparing for AIMS. They can ask question related to the apexum. The procedure is based upon a device that removes the chronic inflammatory tissue through the root canal axis by a procedure that is minimal invasive compared with the open flap apical surgery. When compared with the normal surgery, it is definitely an minimal invasive procedure. So it's going to contain two devices, that is apexum nitai ablator and the apexum PGA ablator. Okay, this is not much important. Just have a look over this. What is apexum procedure? The basic question they can ask in AIMS or PGA. Preferably may not be a choice of question in your Neet. So one more important note is about the periapical index. So on seeing a radiograph, you can come out with an index. So this index particularly helps in follow-up cases, like whether there is a decreasing in the periapical lesion or not. So coming to the calculations, this index is basically 1, 2, 3, 4 and 5. You can give 5 scores. 0 is intact periapical tissue. Score 1, the value ranges from 0.5 to 1 millimeter. Score 2, 1 to 2 millimeters. Score 3, 2 to 4 millimeters, and score 4, 4 to 8 millimeters. And if the diameter is greater than 8 millimeters, then you have to go for score 5. So they are E and D. E is related to the expansion of the cortical bone, and D is related to the destruction of the periapical bone. This is how the periapical index is. Just please make a note of these values. So the last one is endoperial lesion. Endoperial lesion is a relationship between the endodontic and the periodontal lesion. And I hope you know the communications. The communications can be a deep periodontal pocket, or from the lateral canals, or for a molar, it can be through the furcation areas or any accessory ways. You can see the furcation areas here in this diagram. So next is about the classification, the basic classification. Primary endodontic lesion, primary endo with secondary perio. C means it starts as an endo lesion which later turns into periodontal involvement. Primary periodontal lesion, which is primary perio plus secondary endo. True combined lesion is, they are different, like they have both endo and perio, but they are not combined with each other. So this is what primary endo. It has an endodontic infection, which the endodontic infection further leads to periodontal problem. This is primary perio, which causes infection through the lateral canals or from the furcation, leads to the endodontic problem. So it is the primary perio and endo. It is two different. It has both periodontal and it has both endodontal. That is a true combined lesion. So the basic difference, they are well-known differences. Cause, pulpal infection, periodontal problem. Tooth is non-vital in pulpal, vital in periodontal. Restoration is deep in the case of pulpal. It is not related. Plaque or calculus are the primary cause of the periodontal problem. Inflammation is acute in the pulpal, chronic in the periodontal. Coming to the pockets, generally if you see a endoperial lesions, there will be a single and a narrow pocket in the case of primary endo, secondary perio, and there are multiple and wide coronally in the case of a periodontal. Trauma from occlusion may be primary or secondary, and for the periodontal problems it is a contributing factor. Microbes, very few in the case of a root canal, whereas if you go through the periodontal microorganisms, they are very complex and there are many. So coming to the radiological features, pattern of bone is localized. Here is generalized in the periodontal. Bone loss is wide apically. So if root canal, if it is infected, it will be wide periapically, whereas in the case of here it is wide coronally. Periapical radiolucence is seen, it is not related. Vertical bone loss is not seen, vertical bone loss is present in the case of periodontal. Coming to the histology, no apical migration, or in cases few minimal apical migration is seen, generally normal, whereas in the case of a periodontal, it is present and it is largely related to the recession. Treatment, root canal treatment, is the periodontal therapy. So what you need to do? So basically you need to go for the vitality to differentiate the endoperio, whether it is endodontal or periodontal. If the vitality is positive, then you need to go for the periodontal therapy because it is a vital teeth, no need of any endodontic if it is resolved, right, so fine. If it is not resolved, I can check the vitality and do double vitality. So just check the vitality. Even then, if it is not resolved, then you can go for either extraction, recession, or hemisection. Similarly, the vitality, it is non-vital, then you have to go for the endodontic therapy, that is a root canal treatment. If it is resolved, fine. If it is not resolved, then again you have to check for the periodontal and ask the patient to maintain the oral hygiene, and if not, you have to go for any of these treatment protocols. So this is one of the peculiar thing that is most commonly seen. So even after doing repeated root canal treatments, sometimes the lesion may not resolve. In such cases, you can you need some histological things to go for a diagnosis like periapical actinomycosis. As we know that periapical actinomycosis is a chronic granulomatous infection in the humans and animals caused by these two bacteria, and this periapical actinomycosis is a form of cervicofacial form of actinomycosis, and that is a sequelae of dental caries. And you know that this is gram positive, PS positive, and core with radiating peripheral fibrofilaments that gives a typical appearance called as this is very, very important, most common repeat, that is ray fungi, which is also called as star burst. You can see it, they're moving like spikes of star. So no much details, like if these organisms are isolated from the root canal and they are present in the periapical, the teeth may not respond for non-surgical treatment, means non-surgical root canal treatment. In such cases, it is better to go with a surgical procedure. So the next is foreign body reaction, which is also called as a cellulose granuloma or oral pulse granuloma. Okay, so the foreign body reaction can be either due to the gutta percha that is extruding out, or it may be due to the papar points. Particularly, infected papar points can protrude during the through the apical foramen and allows a biofilm to grow there, and this sustain and even the intensify the apical periodontitis after the root canal treatment, leading to the failure of the root canal treatment. And sometimes these foreign bodies can be sealers, can be calcium hydroxide, which is extruded, or the gutta percha can be of two types, that is extruding out. Presence of gutta percha in excess is associated with the interrupted and delayed healing of the periapex. So care should be taken not to extrude it out. And if larger pieces of gutta percha are extruded out into the periapical region, there will be well encapsulated by collagenous capsule, and if fine particles are extruded out, then they will be eaten away by the macrophages and the giant cells. Scar tissue means even after root canal treatment, you can sometimes see a periapical radiolucency, occasionally due to the healing of the lesion by scar formation. That may be few times misdiagnosed as a radiographic sign of the failure endodontic treatment, but it's not a failure actually. So various tissue cells participate in healing process, and the pattern of healing depending upon several factors. There may be the regenerative potential or the speed with which the tissue cells borders the defense and react. So apart from these, the periapical lesions may few times associated with that of cytomegalovirus virus or Epstein-Barr virus. Still the research is going related in this aspect. So the last one is external resorption, and resorption is a lytic process where the osteoclast will get activated, which leads to the resorption of the bone or the cementum or the dentin of the roots. And the causes may be periapical inflammation due to the trauma or excessive forces, or associated granuloma or cyst, jaw tumors, reimplantation cases, bleaching of the teeth, impaction of the teeth, and systemic diseases, or sometimes it may be due to the idiopathic region. The next important thing is about these resorptions in the case of orthodontic treatment, where you can see braces here. So orthodontic treatment can lead to resorption. You can clearly appreciate the resorption, because this is the process by which the tooth moves in general. So though it is developmental, generally the external resorption is asymptomatic. Symptoms are very less. You can see on the radiograph in particular, when the root is completely resorbed, the tooth may become mobile and it goes off. So radiographic signs, you can see a concave or ragged appearance on the root surface. You can clearly see a concave or a ragged appearance here and here. And the treatment of choice is the removal of the irritant, because osteoclasts are going to get their blood supply from the pulp in the root canal. So the main intention of going for the root canal treatment is to kill these osteoclasts which are responsible for this resorption. So once the pulp is removed, the blood supply to the osteoclast is broken, so the resorption ceases. And the treatment you need to go for, the best treatment right now for the resorptions is definitely MTA. So last but not the least, it is a non-odontogenic periapical lesions. Sometimes you may be misdiagnosed with this, so it's better to go with the pulp vitality first. So you can differentiate whether it is vital or non-vital. So if it is a vital, you can suspect something. If it is a non-vital, that can be maybe due to the pulpal infection or due to the pulpal sequelae. So these are the few things: odontogenic inorsion, dentigerous lateral periodontal cyst, OKC, residual apical cyst. Bony pathologies: cementoblastoma, periapical cemental dysplasia, osteoblastoma, cementifying ossifying fibroma. Non-odontogenic origin: central giant cell granuloma, nasopalatal duct cyst, simple bone cyst, globomaxillary cyst. Sometimes the malignancies can be sarcoma, carcinoma, odontogenic tumors like ameloblastoma. The fish zones, I'm just going to post it. I have already posted a pic about these fish zones in the morning section. Just have a look. You can remember it with a code ICIS. This I is at the center, this S is at the periphery. So zone of infection, which is at the center, followed by zone of contamination, zone of irritation, zone of stimulation. This is the periphery one. They can ask the order, and particularly they are going to ask which of the following cells are predominant in particular zone. For every zone there is a particular cell that is predominant, and that is the most commonly asked question. This is the zone of healing, and make a note, always healing starts from the periphery and moves to the center, whereas infection, it starts from the center and it moves to the periphery. It means it starts from the infection zone and it moves to the stimulation zone, whereas the healing process will be opposite. It starts from the stimulation zone and it moves to the infection zone, and means it moves towards the center, the healing process. And I have posted a pic morning with a clear cut and mentioning all the questions, particularly the zone of irritation, which is very important because cholesterol crystals are present in this zone. That is the most commonly asked question. So I hope you have got some stuff with this video, and at max these are my references covering max. Please try to correlate the diseases of pulp and as well as the periodontium. I have posted a video on diseases of pulp. Please go through that. You can have a better understanding all the pressures, particularly about the diagnosis part. There is slight modification in the recent diagnosis part, that is recent diagnosis trends that are followed. I have clearly mentioned those trends. I have seen many questions related to that diagnosis part in the recent AIMS papers, recent AIMS examinations with some sort of diagrams. They have given lots of diagnosis part related stuff. So we have covered in the previous video. Please go through that. They're very, very important in examination point of view, and I hope you guys have enjoyed it, and I feel it is informative for sure because I have covered it my best. And thank you. Signing off, Dr. Srikanth, MDS CONQUER, and please make a note of my number 9989427971. You can ping me on WhatsApp for any inquiries. Thank you, and